Samir Gupta is here from the Division of Infectious Disease to talk about HIV and other things, right?
Remind me, am I the last one standing, the last speaker? Congratulations, thank you. I informed Brian I'd have to go last because I wasn't sure how well my staffing would be in clinic today. We actually got out in time, so I'm very happy to be here in front of you all this afternoon. So I will get started. So I'm going to focus on HIV pharmacogenomics, and that's mostly what I deal with in the outpatient setting is HIV therapeutics. And we'll go over this a little bit because I think it'd be very instructive and just the whole field of pharmacogenomics and how that can impact practice. So we'll start with the case study. So this is a 43-year-old African-American woman requiring hemodialysis for diabetic nephropathy, and she's subsequently found to be newly diagnosed with HIV infection. Her initial laboratories show a CD4 cell count of 185. For those who are not familiar, that's low. So that would actually be an AIDS defining criterion just from that laboratory result. She asked that her initial antiretroviral regimen be as simple as possible, wouldn't we all? Because I have to take all those other terrible medicines for my kidney doctor. I asked her, is Dr. Decker your nephrologist? And she goes, how did you know? And I said, well, he loves his drugs. All right, so we'll move forward. So very, very reasonable request. So you consider a once daily regimen of abacavir lamivudine as a combination tablet with efavirenz, which is another single tablet. She likes adding just 2 pills a day to a regimen and said, boy, treatment sure has come a long way. That is true. So with combination antiretroviral therapy that first became commercially available in 1996, we're taking about 30 to 40 pills a day just for your HIV treatment. And for many of our patients, they're actually down to a single, as Raj would put it, a polypill or a single tablet regimen. So HIV therapy is quite advanced and has become less and less toxic as well. So it's become quite a tour de force in terms of clinical treatment for an otherwise obviously life-threatening disease. You then discuss possible side effects, and she asks, can't you figure out if I'm at increased risk for side effects before I start these meds? What was that whole human genome project about anyway? And I'm like going, you are smarter than all my fellows combined. And what I what I didn't tell her is I can tell you're smarter than I am, and I didn't want to go that far with her and have her lose faith. All right, so here's the first question. And the last person has to go hard. All right, so performance of which of the following genetic tests can help reduce the risk of developing a severe reaction, a true life-threatening allergic reaction to abacavir, which is one of the medicines I'm considering prescribing to her. And I'll let you read through all of those. And do I press a button now? Okay, to activate the time. This is what happens when you don't attend the practice session. So, all right, I'll have to be coached. Then press again. All right. Did you go over this morning? All right, wow. Oh, geez. So I was like going, holy cow, you guys are awesome. All right. I'm going, what am I doing here? All right. So
we also had time to look it up before you got here.
There you go. But that is correct for 97% of the audience. It is HLA B5701. And I apologize again if this is somewhat repetitive, but it's not? Oh, okay. All right. Okay, fantastic. All right, what am I doing here? You already know it all. That's great. So let me discuss a little bit about abacavir and this whole concern about hypersensitivity reaction. Did I skip a slide or did it go right to it? Okay, I think we're good. All right. So what is this HSR, hypersensitivity reaction? Well, it's bad news. So it presents clinically as fever, severe rash, cough and dyspnea, GI intolerance, nausea, vomiting, abdominal pain. The nice thing is, if recognized, it stops immediately after discontinuation of the drug. However, symptoms continually worsen with continued administration of the medication, and it can be fatal. So this is a true big problem with the use of this medication. And even if you say, well, boy, you also started this medicine, you had a rash, could you have just had the flu? Let's stop it, let's restart it. Well, it can be then immediately fatal if rechallenged, if the patient truly had developed a drug reaction. Usually happens within the first 6 weeks of its use, and it occurs in about 8 to 10% of exposed patients. These typically are people of European descent, so they're Caucasian, but does occasionally occur in those of African or Asian descent. Initially, there was a very strong familial predisposition reported, and then subsequently research suggested the multi-organ allergic reactions were commonly linked to an MHC loci. So this is perhaps considered one of the landmark, if not the landmark, trials in pharmacogenomics, and I'm going to review this. So this was published in the New England Journal in 2008, and it's essentially studying the strategy of doing a genetic test prior to initiation of a drug to see if that would improve true clinical outcomes. So the study overview, and these are slides that I've borrowed and are free online from New England Journal. Again, hypersensitivity reactions to abacavir are tightly associated with a specific HLA type called B5701 in preliminary studies. So this was a global, multi-center, prospective, randomized trial of nearly 2,000 patients with HIV who had not received this medicine, abacavir, before, and were randomly assigned to undergo testing for this specific MHC type or HLA type, or to receive standard of care, meaning they don't get that information and the physician does not get that data prior to initiation of treatment. Screening of eliminated and immunologically confirmed hypersensitivity reaction to abacavir was done in this predominantly white population. So this trial was not done in North America. It was primarily done in Europe, some locations in South America, and in Australia. In this case, the trial was to see if a pharmacogenetic test could prevent the toxic effects of the drug. So getting to the final results to understand what happened. So let me, there we go. With the pointer, can you all see the arrow, or should I use a laser pen? All right. Then the population was randomized, as I said, to prospective screening, 803 patients, versus control, those who did not get the screening done at 847, or at least the results were not provided to the physician. There was also predominantly done in whites, as you see here, but analyses were done pre-specified in a white subgroup, and that the incidence of hypersensitivity reaction when clinically diagnosed, meaning without a true immunological test to prove that they've had that reaction to the drug, just based on clinical diagnosis, based on, say, having fever or a rash or some cough, GI upset, drastically reduced risk of developing that toxic reaction. In those who had immunologically confirmed hypersensitivity reactions, essentially getting the HLA testing done eliminated the risk. So you may ask, how do you do that immunological testing? It's basically when you go to an allergist and you get skin testing done, to various environmental triggers. Same type of thing was developed for this particular drug. And in the control population, it still happened, though you can see less frequently in the immunologically confirmed, and we'll talk about that a little bit. But essentially, the test eliminated the reaction because the drug was just then not prescribed. It was not given to patients who had that B5701 type. In multivariate analysis, again, walking through the table because it's somewhat busy, looking at odds ratios for development of the hypersensitivity reaction, just with clinically diagnosed hypersensitivity reaction, certainly reduced the risk by 60%, highly significant in whites versus non-whites. It did not seem to help as much in those who had previously used any antiretroviral drug. The reason why we included the analysis of the introduction of NNRTIs, another commonly used class of medicines with these drugs, are non-nucleoside inhibitors like nevirapine or efavirenz that frequently also have side effects of rash. And so can this actually reduce the risk of a clinical diagnosis of hypersensitivity reaction? Well, not necessarily if they're also using these other medicines. So that's why it was parsed in this manner with immunologically confirmed hypersensitivity reaction. Again, very helpful. It virtually eliminated the risk. And then they also then said, well, what about those who were clinically diagnosed but not immunologically diagnosed? Really wasn't that helpful in that group necessarily. But here's where you see some highly significant odds ratios. Basically what they're saying is that just the presence of fever and rash does not necessarily mean it's a hypersensitivity reaction to abacavir unless you truly had that specific genotype. And then that's when the risk stratification was helpful. In terms of actual diagnostic testing, in terms of giving you sensitivity and specificity values, positive predictive values, negative predictive values, I'll just sort of walk you down through here. In no other study of any type of diagnostic testing or prediction do you see positive predictive values of 61, negative predictive values of nearly 100% with the use of this test. So it really became a game changer in allowing us to safely prescribe the medication to our patients. So in conclusion, with this landmark trial, as I showed, screening for the specific HLA type significantly and virtually eliminated the risk of a hypersensitivity reaction to abacavir. In predominantly white populations, similar to the one in the study, 94% of the patients do not carry the allele and at low risk, but for the 6% who do carry the allele, because it's much more frequently found in whites compared to Asians and those of African descent, it can be extremely helpful. And I've had patients who are Black, are Hispanic, are of Asian descent. Well, we still will do this because occasionally this will still be carried in those particular populations. And they would carry the same risk of a hypersensitivity reaction to the drug just as white populations would. So we would do this before administering the drug in any patient. Okay, so let's switch gears a little bit to a second part of this case. Now we've talked about hypersensitivity reactions. I should just say HSR, make it easier. Talking about the other drugs in the combination that I might want to prescribe. So which of the following groups are more likely to have a genetic predisposition towards developing toxicity from efavirenz, one of the other 3 drugs in the combination I'm thinking of prescribing? And I'll start the clock. All right. Okay. All right. So nearly half would say African Americans and some mixture of Asian and European Americans. Okay. So the correct answer is African Americans would have a higher risk of developing a toxicity from this particular drug called efavirenz, or the trade name is Sustiva, if you've heard it used in those terms. So some basic characteristics of efavirenz. It's a non-nucleoside reverse transcriptase inhibitor, as I had alluded to before in the first part of the case. It's a first-line agent currently. It's part of a single tablet regimen that is frequently given to patients with HIV infection as initial therapy. However, it has a fairly significant Achilles heel. Rapid resistance development can occur through a single base pair change. So a single SNP, 1-point mutation could eliminate its effectiveness in controlling HIV replication. And not only does it affect its own ability to treat HIV, it does have some cross-reaction to other drugs within the class, so it can knock out other medicines within that specific class of non-nucleoside inhibitors. So it has, at steady state, pharmacokinetics, Tmax of 3 to 5 hours, gets up there pretty quickly as a once-daily drug, a terminal half-life that's fairly prolonged of 40 to 55 hours. It's highly protein-bound, predominantly metabolized through the liver, with a mild increase in systemic disposition with intake of food. So the pharmacogenomics of efavirenz are interesting. So the primary side effect is CNS toxicity. So patients will describe dizziness or vivid dreams, very colorful, very active dreams, especially as we recommend to take it at night before going to bed so they don't go to work dizzy and confused and driving and operating heavy machinery. So somnolence, headaches, psychiatric disturbances can happen. It's, as I mentioned, usually prescribed at night for those reasons, so they hopefully sleep through the initial side effect risk over the first few hours after intake. And usually these side effects, if they occur, would peak by week 4 of the use of the drug, and in many patients resolves afterwards, but doesn't resolve in everyone. So we will try to push through with the use of this medicine, saying, we'll give it a couple months, see how you do. And a lot of patients will say, hey, I'm feeling better, I've gotten over it. And many of them will say, well, not necessarily, I still have trouble. And so then we might want to make a change in their therapies because of prolonged side effects due to the medication. Now, a specific SNP, at codon 516, a G to T mutation of 2B6, is linked to increased plasma concentrations of the medication. So it's more commonly found in blacks, 70 to 20% prevalence of a TT genotype. So TT here is bad. And reports of increased virologic failure and CNS toxicities in blacks versus whites using this drug had been reported with initial use of the medication. So a specific trial was performed where 3 different HIV regimens were used, and in 2 of these regimens, efavirenz was incorporated in the trial and the combinations compared. And a specific pharmacogenomic substudy was performed as part of that parent trial. It's called ACTG 5097S, the substudy of the parent ACTG 5095 trial. We were a site in this trial, enrolled many patients in it, close to 10, 12 years ago now. And just to walk you through the specific genetic polymorphism that we were mentioning and concerned about earlier, cytochrome 2B6, a G to T mutation at codon 516, in all the subjects in the trial, you can see the frequencies of this polymorphism, about 8.9% in the entire study population, much lower in European Americans, 1 out of 5 in African Americans, and a little bit in between in the Hispanic subgroup. Getting down to the actual pharmacokinetic data that was obtained as part of this sub-study, walking you through it, if you see the efavirenz AUC, 0 to 24 hours, in the GG and GT genotypes, fairly similar. It's when you get to that TT genotype that you see the exposure systemically go up fairly remarkably. And this happened across the board in the entire population and persisted over time. Here you can see the actual raw numbers. You see in the GG, GT, TT genotypes how the systemic exposure goes up fairly dramatically across the genetic distribution, and of course would be highly statistically significant. What was important to note is that this did appear, I'll apologize, a distinct clinical correlation was observed. And because, as I mentioned, this particular genotype was found more frequently in African Americans, in the parent trial, blacks had a shorter time to discontinuation of the combinations, including efavirenz, primarily due to self-reported rates of non-adherence because of side effects. So it did seem that the increased side effect profile from having greater exposure to the drug did have an effect where the patient said, this is pretty bad, I don't like it, they stopped on their own, and then they developed virologic failure because of stopping their regimen, and subsequently would develop resistance and would have to be transitioned to other combination therapies. So again, the hypothesis, which I think is fairly well supported, is that the greater exposure to the medication in blacks caused more toxicity, more drug discontinuation, and greater virologic failure. You can imagine at a practice where I'm at Wishard, where nearly half or slightly over half of our clinic population are African Americans, this could have a fairly profound effect on choosing which drug might be best tolerated in that specific population. I just want to bring up, and I completely admit giving myself some publicity here. So I collaborated with Steve Hall, a former member of the clinical pharmacology division here at IU, in a study through the AIDS Clinical Trials Group, evaluating the drug disposition of efavirenz, specifically in patients who already had end-stage renal disease and requiring hemodialysis. We did some steady-state PK within this subgroup. We had 13 patients in those receiving efavirenz. We also did a similar study in patients receiving a protease inhibitor called lopinavir, and we compared these to historical controls, and we explored pharmacogenomics. And you're thinking, well, I didn't think you could do pharmacogenomic studies in only 13 patients. Well, we managed. We got lucky. So what we did is basically just do a steady-state pharmacokinetic study in patients already receiving the drug, and you can see our results. Bring this here. So this is the 24-hour concentration profile over the entire dosing period with efavirenz, and then I mentioned the protease inhibitor lopinavir. And you see quite a bit of variability. There's always some variability with efavirenz, so this is nearly double what we would have expected. And when doing geometric mean comparisons to historical controls, we did see that the efavirenz exposure was fairly significantly high, though not statistically significant necessarily, with genotyping being done. And again, that bad TT genotype, even in just the 2 patients out of the 13, which we would expect since most patients requiring hemodialysis with HIV happen to be African American, we found a significant correlation. It could explain the variability because of that genotypic predisposition. So you can say, well, hey, you do screening for abacavir, that could be very helpful. Why don't you do it? Because we don't do genotypic screening for this very commonly used drug, especially because it's part of a single tablet regimen. So 1 pill a day. And a lot of times patients will come in and say, yeah, found out I'm infected, but I have friends who take this medicine that's just 1 pill a day. That's what I want. And this is one of the drugs in that combination. So you could ask, well, why don't we do genetic screening? Well, one issue is, well, if symptoms do develop, as I mentioned, you could easily make a change to another medicine. You can easily make a change. Symptoms are not necessarily considered severe. So we're not necessarily dealing with a fatal hypersensitivity reaction that if we guess wrong, we guess bad. I mean, that could put somebody in the ground. And we do see, however, that symptoms and drug concentration dispositions are highly correlated, and this could have an effect on subsequent regimens. So hopefully we'll be able to screen for this as part of Dr. Flockhart's new project in the clinics at Wishard. And that is one of the studies that is being anticipated to actually screen for this 516 GDT mutation and see if that actually leads to different prescribing patterns in our clinic and hopefully lead to better outcomes. And I will stop there. Are there any questions?
With the example that you just got, I'm in cardiology, so I know nothing about infectious disease. I'll let that be said. Do you use that screening, or if you do use that screening, to lower the drug level in those patients? Or is that not going to be I mean, in other areas, in warfarin therapy, we could do that. But in this case, with the viral load and such, can you comment on that?
No, that's actually a superb question. So that strategy has been employed in other parts of the world. So in Thailand, for instance, they have done these studies, similar studies, and they now routinely prescribe efavirenz at 400 milligrams, not 600, to address that. Why wouldn't we necessarily do that? Because no longer can you use the single tablet regimen. You've now broken up the drug and now have obviated the inherent attractiveness of using efavirenz, because you then have to say, well, we could do this, but it would be giving 2 drugs once a day, and all of a sudden it's like, whoa, no, let's go somewhere else, because I want once daily and 1 pill a day. And so it's actually just for that very simple reason. We rarely would prescribe efavirenz in most of our patients as a separate pill, if not as part of the single tablet regimen. We do it occasionally, but it's very rare. Oh, I see. I'm not aware of data suggesting that. So I don't think that the PK profile is different with the resistance mutation. No, I don't believe that's been shown. Okay. So we'll make a plug in general, even though you may say, well, you'll refer those patients who are newly diagnosed to me. Less than 1 in 300 people in the United States are HIV infected, and so this will be seen in all of your practices at some point. And so with a lot of drug-drug interactions, as Dr. Fublanchi can attest to, a lot of drug interactions with our co-infected patients and just with any type of medicine. So in cardiology, our drugs will interfere with your drugs in gastroenterology and nephrology in every field. So if there are any questions or you want to run a case by me, I'd always be happy to talk on the phone. So thank you for your time.